Greetings from Jacksonville Pharmaceuticals Limited, makers of Lycorate Plex sachet of L-arginine, lycopene, and DHA in orange flavor, and myoinositol and D-chiron-inositol as Cystelia M tablets. On behalf of Jacksonville Pharma, I, Dr. Vipin Tyagi, welcome you to the AOGD-SAFOG Webinar on non-communicable disease with a special reference to obstetrics.
I can वैसे डॉक्टर हेमा को तो ऐसे ही इनवाइट किया जा सकता है because everybody knows Hema, and Hema ko to we can have the heart and can invite Dr. Hema. Hema is something I can say only in word. If I say the most smiling, ever charming, and the dynamic personality in the Foxy, whom everybody think that she is my only friend. That is the exact definition of the Hema, which I can think from my heart. Although just to do my duty, she is a past president of Foxy, and at present, I will not read it, Hema. Don't mind. And at present, what she is holding on her shoulder, the biggest responsibility of the Manyata, which has absolutely changed the face of the clinical practice, especially for the small nursing homes, and a very great thing for our semi-skilled health worker. Hats off to the Hema, to you for that wonderful thing. And no doubt she is a great academician. Over to you, Hema.
Thank you so much, Ragini ji. And she's a very distinguished office bearer of Foxy, and her presence adds so much weightage in terms of esteemed professional organization, with the representatives being so involved and so committed. Thank you for your presence here. Sadhna ji, representing SAFOG for the entire country, has led many initiatives and stood shoulder to shoulder. Malaji and AOGD, who with Jackson Paul have put us all together. With my respects to Chairperson, Dr. Chowdhury, and Alka, my very beloved friend who is yet to join us, I may in right earnest share my slides and start my deliberation with what Ragini said, that she speaks from the heart. So we launched a program called Sweetheart, which means a sweet disease today can become a heart disease tomorrow. That is the long-term implication of diabetes in pregnancy, which turns into a non-communicable disease. So that's the crux of this entire deliberation of why should OBGYNs be bothered about NCDs? Well, a couple of years ago, to be precise, even just as recently as 5 years, Ragini will agree with me, Sadhna ji will endorse it, I'm sure, that even the expansion of NCD, you know, people started saying, oh, is it the National Commission for something? Oh, Hema is working in diabetes sector. Maybe it's Diabetes National Forum for Diabetes, etc., etc. So non-communicable diseases has come to the forefront, much on understanding the connection between the OBGYNs, the environment in utero, and moving on later in life to non-communicable diseases. So ladies and gentlemen, it's both a challenge and an opportunity for us to tackle this menace of obesity, high blood pressure, heart disease, and diabetes. These are the NCDs, which are now defined as the leading cause of death in women, globally accounting for 2 out of 3 deaths annually. And that is a mind-boggling number. There is insufficient recognition. People may think in Nepal, Bangladesh, India, low middle income countries, okay, maybe high blood pressure, obesity is something to do with the affluent countries and it doesn't hurt us. But the truth is that the majority of these NCDs are, as expected, emerging from the LMICs or the low middle income countries, and we need to pay a lot of attention. What were we doing, the SAFOG region? obstetric emergencies. We were in the frontline runners for managing obstetric emergencies, saving lives, saving mother, saving baby, etc., etc. Well, friends, let me tell you, that was yesterday. And today what we are dealing with is a tsunami of the NCD emerging out of these pregnancies. She is a diabetes in pregnancy. She becomes type 2 within 2 to 5 years. So whether in Bangladesh or Nepal or India, with whatever sparse statistics that we have, we know that even if she's delivered at 22, undiagnosed or late diagnosis and improperly managed diabetes in pregnancy, nobody looks at her ever after. And by the time she's 25 or 28 years old, she has become a full-blown type 2 diabetes, which means that what originated from pregnancy has now shifted on to her lifetime disease of NCDs. So tomorrow, the situation will be that the entire new generation may be only shrouded with the cardiovascular diseases, hypertensive disorders, obesity, diabetes. So that, ladies and gentlemen, is a connection that we need to understand between the OBGYNs and NCDs. So 80% of the deaths because of NCDs are now occurring in the low middle income countries. So we need to pay urgent attention to this. And this SDGs, or the Sustainable Development Goals, does recognize NCD as a very major challenge, and to reduce the premature mortality because of NCDs by 2030 is a great challenge indeed, and we need to understand and act now. What does FIGO believe? Sadhana has put the title as, what is FIGO's perspective? Well, I happen to be the vice chair of the FIGO PNCD committee, Pregnancy and NCD committee, which means we strongly believe, and it's a true fact, that everything is a vicious cycle because it all starts in utero. There is a pregnancy complication. This little baby in the womb is growing in an unfavorable environment of a pregnancy-induced hypertension or a diabetes in pregnancy, and later he or she in young adulthood blooms into non-communicable diseases. So that is the grip that FIGO wants OBGYNs to have to tackle the target group of pregnancy, because it all starts in utero. And how does this happen? It may be a healthy pregnancy, but as the pregnancy goes on progressing, there may be a situation of low birth weight because of preeclamptic toxemia, hypertensive disorders, or there may be too much weight because of gestational diabetes and related issues. So what happens to these babies in the adult life? They get at elevated risk for obesity, cardiovascular diseases, diabetes. So it is non-communicable in adulthood, but in pregnancy, it communicates from generation to generation. From the mother, in the wrong environment, this baby is groomed into becoming a at-risk person for NCDs. So intergenerational communication is what we have to completely and correctly recognize. So though it is non-communicable in a sense of after being born, you cannot give the diabetes to your neighbor, but in the mother's womb, yes, you can be programmed to have diabetes in adulthood. So the Barker's hypothesis of fetal origins of adult diseases, maternal undernutrition, maternal stunting, maternal anemia, malaria, and other medical conditions, are they not common in countries of SAFOG? Yes, certainly, and many low birth weight babies are born. Now we are swinging to the other extreme, maternal overweight and obesity, with 1/4 of our women everywhere in metros, especially sedentary lifestyle. Yes, it is a forerunner for diabetes, excessive weight gain during pregnancy, and with the Peterson's hypothesis, it's macrosomia. So what predicts the development of hypertensive disorders, type 2 diabetes, or impaired glucose tolerance in adulthood, all begins in utero. So the solution is to offer a life course approach. What is the life course approach? Is it only because of the prenatal nutritional factor and these environment which we are talking about? No, that is a genetic fetal programming. By the time it gets to adult onset diseases, there's also something of the epigenetics. The way this child grows, bypassing the childhood obesity and growing into an young adult with all the lifestyle modifications certainly will reduce the chances of adult chronic diseases. If it's out of sight, out of mind, nobody is recognizing this and telling anything to this population, you will surely land up with a tsunami of NCDs. Prenatal to postnatal, a lot of factors which transit and make the entire generation into case of NCDs. When we mean life course approach, what do we mean? We as OBGYNs have to necessarily invest in the best of the care of the mother and the child, because you see that when the best is done here and this infant is programmed in a normal environment without hypertensive disorder or very well managed hypertensive disorder or well managed hyperglycemic disorder, then the chances that either the mother or the baby will develop NCD is so small during the life course, that is the early intervention. You have missed the bus here. There is another time you can catch them in childhood and adolescence. The obesity, lifestyle disorders in adolescence, which is a forerunner to the future NCDs, again can be brought down by intervening here. And in adulthood, if you do nothing, no intervention, just imagine the scale of the NCDs that the world has to face. So we as OBGYNs have got one targeted opportunity, as in the best care of the pregnancy. So the primary prevention of making her enter pre-pregnancy weight gain, etc. should be monitored. Obesity, PCOS, lifestyle are so much in nexus that we have to break this nexus and do our best. The secondary opportunity for prevention is when she actually gets pregnant, test her sugars, blood pressure, and get your handle on the best of the care so that both her long-term problems with NCD and the child's long-term programming for NCDs gets minimized. Well, even if that has gone by, we have an opportunity to call back our postnatal women every single year, especially if you have handled a case of preeclamptic toxemia or a diabetes in pregnancy. Please don't let go of your sight from them every single year. If they come for an annual checkup, these are potentially the ones who may get into an NCD phase very early in their life. So from 25 to 35 to 45 to 50, if there is a constant vigilance, you would have played your role well as a primary care physician of the girls and women in your own country. There are a lot of things in our part of the world, the SAFOG regions, suboptimal nutrition, the change in physical activity, the inaccessible, unaffordable prenatal care, and the new era problems with alcoholism, smoking, etc., growth restriction, adult onset diseases, as we've said. So our best opportunity, what the FIGO thinks, is the opportunity of the window of opportunity that the pregnancy provides. Reduce the traditional method and perinatal morbidity mortality indicator. You just get them to saving lives. That is your primary motive, but also address the intergenerational transfers of the NCDs and have a handle on the diabetes, hypertension, cardiovascular diseases, and stroke. Just taking one example of hyperglycemia in pregnancy. If you bother to care for our girls and our women right from adolescent, pre-pregnancy, in pregnancy, postnatal, and in their early childhood, that is the life course, and you will be able to contain the tsunami of the NCDs in the future generation. The occurrence of hyperglycemia in pregnancy, if you have millions of pregnant women with diabetes in pregnancy, for example, then you will have a proportionate number of population with type 2 diabetes in the women of that country. So this is the link that you got to relate to and do something when you have the opportunity in pregnancy. So we have to establish the services, improve the health, and prevent the intergenerational transmission of the non-communicable diseases. Coming to think of it, the SAFOG regions contribute 20% of the global burden. It's a huge number. Even if 10% of our pregnant women in India alone have been recorded to have gestational diabetes, we are dealing with 3 to 5 million pregnant women in the country with a situation of hyperglycemia. So our area or our zone of the SAFOG regions is very different. You will see us all discussing very strongly in the FIGO circles. What can we do? How can we offer a simple, practical, pragmatic guideline for the diagnosis and management of care of these disorders in pregnancy, one of which was the hyperglycemia in pregnancy. That's the first guideline we brought out, adaptable to the South Asian regions. You will see Dr. Moshe Hood, the chair, and myself as the vice chair there, with a whole group of people who listened to our voices, who had the maturity to say that yes, everything that can be done in the West cannot be done in the SAFOG regions. So the guidelines have been revised for our regions, which we urge you to look at the FIGO website and try and implement it to reach every girl, every woman in your own countries. There's also a guideline on hypertensive disorders, which is slowly emerging. There's the third guideline on pregnancy, obesity, nutrition intervention. So there are a lot of things with the recognition from FIGO that we need to innovate alternative methods of testing and care. And it has to be done in keeping with the resources of that country. You cannot say diabetes in pregnancy needs a dietitian, needs a lifestyle coach, and needs a motivational person to guide them, needs an endocrinologist, needs a counselor. From where can you manage to get all these in countries like ours? So that is not practical. So how do we spin around the care, taking the responsibility on ourselves and do the best? So the guidelines have been laid out. Testing, medical nutritional therapy, for the use of metformin, insulin, for the monitoring, intervention, and post-delivery care. Universal testing in SAFOG regions is an absolute must. Do not bother to inquire if she has had her parents with diabetes or a large baby in the previous pregnancy, etc., etc. Just if she is an Asian woman, she is at 11 times more risk. Please, please urge all OBGYNs to test all pregnant women. And the test that we use in the South Asian region is called the single step test, fasting or non-fasting. Whenever the patient comes to you, don't lose out on the opportunity. At 12 weeks and 20 weeks, that is 2 times in pregnancy, offer her a 75-gram glucose mixed with water, and 2 hours later, she just gives 1 blood sample, and if the value is more than 140 mg/%, she's labeled as a case of gestational diabetes. The lab is far away. If they cannot go and seek the laboratory report, well, our government has also approved of the point of care. Just have a glucometer. If she's coming after 75 grams, 2 hours with the finger prick, at least you'll get the approximate idea. If the glucometer check shows 380, for example, which is not surprising because she's never ever been tested before, that is your cue to pick up and initiate early treatment. So even the finger prick method has been approved by FIGO. In India, we do the universal screening for all our pregnant women at booking, that is at 12 weeks, because that's a good opportunity to pick them up early. If that test is normal, we need to repeat this test at the peak appearance of the hyperglycemia, that is in the mid-pregnancy, 22 weeks, 24 weeks, 26, 28 weeks. 90% of the women presuming they're negative, 10% will be positive. This test, single step, is very easy to execute. What do you do with these positive women? The first thing is the medical nutritional therapy. FIGO offers no concessions in this. May you be from a high-flying city or in a rural area, all. You see the resource setting. All resources have to give a proper medical nutritional therapy. That means the diet advice and the exercise advice, no excuses to be made in this. We follow the signal system, which is very easy to explain to the patient. We say fresh fruit has fibers, so you eat that, you're in the green zone. If you eat a sweetened fruit, then that is in the amber. And if you take a processed fruit, as in a canned juice, then it goes to the red zone. So simple ways of making your patient understand what this medical nutritional therapy is all about, and about how much exercise you have to do. Again, you note the resource setting. There is no distinction. All resource poor and resource rich countries have to advise diet and nutrition. So the pharmacological management, metformin and glyburide are included in the FIGO guidelines. You have to pay attention to her diet, her sugar control, the weight gain, and achieve the targets, and counsel the entire family. Please motivate all your staff nurses to know about this situation, so that everybody speaks with the same concern, same voice, same message, so that it is emphasized and re-emphasized. Not only in pregnancy, you must aim to keep her sugars and her blood pressure in the normal range, but please do not let go of her postpartum. Call her back at 6 weeks, repeat the test, guide her with the right advice, and call her for annual checks again and again, and definitely before her next pregnancy. So do not allow the women from hyperglycemia in pregnancy to move on to the diabetes too after pregnancy. So the life course approach to the management, to the prediction, to the prevention of NCDs of the mother and offspring is the mission and vision of FIGO. So in keeping with the topic of how does FIGO look at NCDs, we have recoined the name of our committee itself as PNCD, pregnancy and NCD, because they both are so strongly linked that let's not lose sight, let's not lose the opportunity to do our best for the women who are with us throughout pregnancy and throughout life. So to stop the dip from becoming a DAP, that is diabetes in pregnancy, to becoming diabetes after pregnancy, that is the mission and vision of FIGO. So this not only applies, ladies and gentlemen, to a particular issue of NCD as in hyperglycemia in pregnancy, this also applies to all other NCDs where pregnancy, no excuses made, it is one of our best targets to invest in for short-term and long-term advantages. So that was all about the FIGO perspective of NCDs, how it all starts in utero, and how the OBGYNs have to take the responsibility on their shoulders to prevent the tsunami of NCDs and get a healthy generation next. Thank you very much for your kind attention.
Thank you, madam. That was really a very informative deliberation, and we should all see that DIP is not converted into DAP. That should be our mission that we take home today.